And I are really excited to be here today, and our presentation, we have the charge to provide resources and practical information following this great presentation that Wendy Stone has done. And since we have such a great amount of information, we've created a PowerPoint that will be linked, and you will notice hyperlinks throughout the PowerPoint that we're hoping that you'll go back to and find the detail that you might be interested in, because we realize that there's a huge diverse crowd out there with different amounts of experience, different amounts of interest, different amounts of training, and different disciplines. And I think it's within that spirit that we are focusing on collaboration. I think with our diverse interests and backgrounds and these diverse family needs that we come in contact with, the thread of collaboration is one place where we can increase outcomes for children and families. And so today, in this day of doing more with less resources, we are going to talk about collaboration, and this has certainly been a process as a clinician in a mental health facility and working with Mary at the Department of Education. This has been a process of collaboration, which I think we've both learned from as well. So today we would like to review guidelines for eligibility and consider that collaboration can occur right from the start, right from that screening process. And if we do that, again, we'll improve positive outcomes because we can use the information to match families with services so that they can get their referral concerns met and get support. And it also creates a support network for each of us as professionals to improve outcomes in our problem solving around working with families. So collaboration begins as a family enters at any given point, at any agency, and it might be for speech and language services, it might be for educational services, it might be for mental health services. And as we get those referral concerns, we're structuring evaluation and moving and looking at eligibility criteria so that we can determine what comes next. But in that process, there's a relationship, and that relationship is the cornerstone. And those of you working with families know that this is where science meets art. Each family that walks through that door has a different set of risks and resiliencies, and we can have a protocol in front of us or a framework in front of us, but we need to adapt that according to each family, as we've learned today, just to individualize the intervention and the treatments. So I'd like to just take a second to show you a video clip of a parent talking about her memory of the evaluation experience of her young child. It's actually a couple of years later, but I think the words that she uses and the context of how important the relationship was, not only to guide her child to better outcomes, but to support the family through the process.
Well, I would say that one of the biggest concerns and challenges we've had to work with as a family is that our son is really, once he's comfortable with someone, has a feel for them and has some trust and a relationship with them, then we feel like he can handle a lot of changes and transitions and things. But it takes him a while to get used to someone, to get a feel for them, and to develop that trust. And so he's always been highly attached to my husband and me, always found it really difficult. Our first evaluation was really challenging because just the separation. Sure. For him to be in a different room from us when he was 3 was just almost impossible. And so that's caused a lot of anxiety and stress for him and for us whenever he's working with someone new.
So I just think a point to make, again, while we're collecting data, there's a family in there that we need to be talking with, understanding, and supporting in the process. And even children with autism spectrum disorders. And it really rang true when Wendy was talking about how we need to be in tune to how hard families are working to help kids through these transitions and through the process, and it can be a stressful experience. But evaluation is that path that starts entry into service and eligibility. And there are multiple classification systems. And it's not the case that one agency can do all things. And we have different systems of eligibility and funding and resources. And so Mary's going to go on and talk a little bit about that process of screening, and we'll move on to talk a little bit more about educational, medical, and clinical guidelines.
Minnesota is unique in many ways. One, that we're a birth mandate state, and we give services down to birth for children, so that becomes important. In screening in Minnesota, too, has a nice network of collaboration just in general. If you look at comparison of different Minnesota comprehensive screening programs, there's the early childhood screening that we do in the schools for 3, 4, and 5-year-olds. There's the Head Start screening, and this link can provide just general information. Department of Health takes the lead on a lot of teen checkup screening. So screening occurs in all of those, even separate than the medical your primary care physician. So looking at it through the educational lens or just the state lens. Also, there's an interagency screening task force. I sit on that, and I see some members also here today. It's the Department of Health, Department of Education, and Department of Human Services gets together, and they review different screening for different purposes. Their general screening for developmental and social emotional concerns, which is required. Also, Minnesota rules and statute govern what is required for the different screenings, and that link will take you to those so you can see them. The CDC recommendation for developmental screening, if you haven't been on it, is a wonderful resource, certainly to share with parents. When we were asked to do this presentation, one of the things was that they wanted information from an educational lens, and they wanted information from a clinical lens or a community setting. And what became apparent to Pat and I as we worked through this presentation was that the lenses that the parent must put on as they go through these different systems. So I like to think of the parents as wearing bifocals or trifocals, trying to maneuver through the system when one system talks about it differently. The CDC recommendations on developmental screening, that link will take you to some nice interactive tools that a parent can access in their home, which I think is important and beneficial for them. Resources for screening, Minnesota has done a lot of nice outreach where they've attempted to give information via a lot of different languages and a lot of different venues. There's the printed brochures that can be ordered from the Department of Ed that are translated in the various languages you see there, which becomes important for different areas of the state depending on the pockets of population. There's also an early childhood video screening that has been translated to the various ones. The ECHO website, which is the Emergency and Community Health Outreach, gives a lot of information for general health and information in general, rather. But there's specific ones tied to early childhood screening, and there's specific ones tied to getting help, early childhood special education, help for young children, and for school readiness. So I encourage you to go to that site and pick those, share those with families. Minnesota currently has 95 what we call IEICs, and those are 95 almost points of entry for a parent trying to access birth to 3 services. There's a new initiative called Help Me Grow to try and give a state identity. So if a physician or a clinic gets a child who maybe didn't pass a screening, that physician knows, who do I call? What kind of information do I give out? There's also the Minnesota Parents Know website, which is a nice landing page and has been recognized nationally for providing a lot of information. There's some autism-specific information, just general developmental milestones, A to Z topics, podcasts. So that kind of will help us all better understand each other's networks also.
I'm going to just briefly look at classification comparisons. We're actually going to go into a little bit more detail, but this is a table that will be a resource for you to understand that after screening, a family could be, again, directed to a number of different entry points, and they might be looking at more educational guidelines or more clinical guidelines. And we will break down those components and talk about both the similarities. And in particular, when we're heading an evaluation, there is some overlap. Both processes include good standard observation, testing, and interview procedures, which may differ slightly depending on the tools that you use, but there's actually quite a bit of overlap.
Okay, looking at an evaluation, if we go back to the previous slide, included, as we looked at the different sources, we felt that observation, testing, and interview cut across all systems for good practice, and those were important. The evaluation should really support the parent referral concerns, and I go back to the information that Wendy pointed out too, that a parent notices it at 17, 18 months. The identification occurs much later. They have a lot of years of information that they've stored up waiting to tell somebody. Generally, it's good and useful information. The evaluation determines the eligibility to services, different programs, different services. Those three components really are important across all the areas in all the settings. We'll go through those in a little bit more detail and talk about what they are. But the interview, standardized testing, really, and the observation help build that informed clinical opinion, eligibility, and referrals. The interview supports the opportunity, like I said, for caregivers to give the information that's not afforded them during maybe standardized testing or observation. And when you go back to the National Research Council in their book, the concerns expressed by mothers were they worry about their children's welfare, their child's inability to function independently, and the community's acceptance of the child. This is where those concerns and worries will come out. That'll help not only guide your evaluation, it'll help guide your treatment. And at the Department of Ed, especially in early childhood, we've had a tremendous emphasis on what we call a routines-based interview. And we feel that the interview should integrate the family's routine and help to identify the concerns, priorities, and resources of the family. It is required by Part C to look at the concerns, priorities, and resources of the family. And it also gives you a profile of that child. Interviews in the medical or clinical field many times are used to help with differential diagnosis. The medical and clinical field have the DC 0 to 3 and DSM-4. We have what we call IDEA. We work with our categorical disabilities. Testing is standardized, could be norm referenced, criterion referenced. In early childhood, we look at measuring general developmental areas as well as going across to specific eligibility for, say, autism or speech and language. The observation, that really supports the gives qualitative information that the evaluator may need. And it can be structured, not non-structured. Okay. Going into education specific, our policies and procedures are defined by the Individuals with Disability Education Act, or as we refer to it as IDEA. In Minnesota here, our Part C is birth through 2, and again, it's under the lead of the Department of Ed. Part B is 3 through 21. There are different ways and avenues for children to access services, and Minnesota is very unique in that way as far as the education field. Part C from IDEA does require informed clinical opinion. And that, okay, because we don't have internet, so we're not going to be linking. Informed clinical opinion gives the practitioner in Part C, they're required to use it. Ask that they take their qualitative and quantitative information, integrate it into good practice. And that's a theme that I think really should go through the rest. These rules 35, 25, 13, 50, that's our rule in Minnesota rules that gives infants and toddlers services in Minnesota. The children 3 through 6 have a different one, and autism spectrum disorder is also in there. A side-by-side of how Part C and Part B eligibility may be different. There's 3 ways for a child to be eligible. They can have one of the 13 categorical eligibilities, as we call them. Autism spectrum disorder is one. So if a child has one of those, has a diagnosis from an outside, they may or may not fit the educational. The Department of Health has done a wonderful job in taking the lead on developing the website for what we call our diagnosed conditions. Oh, sorry, can't get in, one of them. Diagnosed, if a child has a diagnosed physical or mental condition with a high probability of resulting in developmental delay, whether or not a need is demonstrated, they're eligible for Part C services. And you can see the side-by-side for that for Part B when they turn 3, they need an educational need. So that has to be determined. Or they can have, for Part C, 1.5 standard deviation in one or more of the 5 developmental areas, and those are defined in rule. And for Part B, if they're 3 to 6, then you want to make them eligible for developmental delay. They receive services, they need delay in 2 of those areas. So you can start to see some difference. And if you're a parent and you've gone to your pediatrician, how all these different informational points can be certainly confusing. Once eligibility is determined, the team sits down to develop an IFSP if the child is birth through 2, or an IEP if the child is 3 or over. In that plan, there are the strengths of the child, the educational needs, the needs of the child's goals and objectives, what you're going to be working on, services necessary, speech, OT, PT, what types of services, the setting and location, where will this take place, the intensity of services, how many hours, how long. And there's ongoing progress reporting through this. And Pat will talk a little bit about the medical evals, clinical.
Understanding eligibility and entry points across services helps us understand when a family doesn't meet eligibility but they still have concerns, helps us understand where to refer and again get needs met. And so if we look at medical clinical evaluations, this process might have some similarities as well as differences, but this is really based on the referral concerns of the parent coming into the clinic. And while there might be an overall question about autism and whether the diagnosis is validated or questioned on the part of the parents, there's usually also a specific concern. Parents come in and they talk about, my child's not sleeping and it's disrupting our daily life. I can't get outside of the house because my child's tantrums are so difficult. I can't. I'm uncomfortable. I don't know what to do about them. So there's usually a specific concern, and this specific concern is what is driving, I think, all of us to collaborate and make sure the parents' needs get met. The process is certainly influenced by these concerns, but there may be other factors. There might be cultural factors that influence the process of evaluation. There might be medical issues. There might be other factors such as financial eligibility that even some families may be looking at insurance dollars or scholarship dollars or county dollars, or perhaps the family is homeless. And so all of these factors will influence the process of evaluation and eligibility. We also need to keep in mind that there might be other services the family might be seeking, for example, in the community. And so if we know that up front with an autism diagnosis that a family might be seeking out county services, it's important to know what kinds of tests are required and what the eligibility requirements are so that we can help the family through the process. So in a clinical diagnosis, we have a couple of options. The DSM-4 is one that's familiar. You can look at the criteria by connecting on this hyperlink. The DC 0 to 3 is another option for us. And when we talk about how behaviors in very young children are different from behaviors in preschoolers or older children, this diagnostic manual actually gives us some framework to look at very young children in a multidisciplinary way in the context of their relationship with their caretakers, and gives us developmentally appropriate and behaviorally defined descriptions of behavior that might be seen as concerning or at risk. And so this is a tool that can identify symptoms. While we may not, the diagnosis of autism is not unique to DC 0 to 3, there are other symptoms such as a regulatory disorder that might be demonstrated in a very young infant or a young child who is not yet eligible in meeting the criteria, and we wouldn't want to head into a diagnosis of autism. So this allows us to look at these symptoms and assign a diagnosis, for example, of regulatory disorder, and serve this child and this parent and provide them with intervention before an autism diagnosis may or may not be used at a later point. So again, I'm not going to go into detail. I will say that there is a state initiative to offer training to people from a wide variety of disciplines on the DC 0 to 3. And if you click on the previous slide, the DC to 0 to 3R, you will get the link to the Department of Human Services and the trainings that are offered that you could participate in a minimal cost. The 5-axis framework for the DC 0 to 3R is a bit different, and philosophically, again, when you're working with very young children, these children are developing in the context of a relationship. So axis 2 identifies what requires intervention in the relationship so that a parent can help scaffold the gaps in development that are occurring with a child that is showing, for example, regulatory issues. And then axis 5 looks at rating social emotional functioning in the context of relationships across settings. So if you're able to rate the degree to which a child shows behaviors or skills in a particular context, you can find out a lot of information. Perhaps that you find in a very structured relationship, this child shows higher skill abilities and its strengths are more apparent. And you can use that information then to help others who are with the child in relationships, whether it be daycare, or in the home setting or other caretakers, use those skills to help, again, scaffold and fill in the gaps. So medical and clinical evaluations may result in a diagnosis, but eligibility for services might include some additional components. Briefly, we look at medical necessity, and then there is the component of insurance eligibility. Families have different contracts, and so referring for evaluations may not guarantee that their insurance provides one. There are some resources, again, though, in the community, such as TEFRA, that you might be aware of, and there are links to get information as we talk about community services. Also, it's worth to mention that medical and clinical services come through two systems of payment, and it's important to know this in terms of what services might be available. Mental health and behavioral interventions would come from one system and pathway of funding, and rehab services and medical issues, which certainly often occur with children with an ASD diagnosis, would come out of medical benefits. And so knowing that there's eligibility and services in those two different systems can expand the kinds of interventions. When we survey our families who are getting the most intensive intervention in our clinic, we find that on average families are getting about 7 interventions with different agencies. So the notion of collaboration makes good sense so that we can be working together in the team to be able to provide for the family's needs. With a clinical diagnosis, family can pursue additional services through county, state, and federal programs. In addition to the diagnosis, they may need IQ, cognitive testing, as well as adaptive functioning, so we're going to make sure that that's a part of the overall evaluation. And then there may be financial criteria that the families go through. Again, being aware of this can help us guide them to a place where they can gain more information and access services that they are eligible for. You can look at some of these services through these hyperlinks after the presentation today, so I'm going to skip over that and just reflect back that we're hoping that once you understand the eligibility, you can help to guide families to access services which match their initial referral concerns. While family concerns drive the process of evaluation and treatment, collaboration really drives the process that links services to professionals and creates that team that's so important to guide families. And while eligibility guidelines provide us a way to collaborate around evaluation, evidence-based practice really provides us a way to collaborate around treatment. And I think when you use your relationship with families within the context of a relationship, your interactions really model a model of collaboration that's going to be important throughout the child's development as they grow. So there's good reason that collaboration is a good match for helping families access services for their children. And it is a model of promoting children and families first. It promotes a consistent language. It minimizes confusion. I'm sure you have families that are coming through the door and saying, what's the difference between ASD and PDD? Knowing those different systems helps us describe and frame things in a way that will help us work together as a team rather than create conflict and disjoint things. A good collaboration, again, guides families to services that are linked to referral concerns, services that are identified with good evaluations by multiple disciplines, services that are linked to eligibility, that are clearly described in the intervention plan, and clearly described criteria for measurement and outcomes, and training families to how to measure. So when they come in with that initial referral concern of my child isn't sleeping, that there's check-in and all levels about, well, what is that looking like today, and helping families learn how to measure that.
Just going back to what Pat said, on the page that we couldn't link to that I was going to show, on the conditions with a high probability that is hosted on the Department of Health website, under the social emotional category, we accept Access 1, DC 0 to 3 diagnoses as a condition with a high probability. So you can start to see how there's a natural weaving of eligibility across the systems. We just need to be aware of it. That's not to say that educational people will be versed or trained or that they can be in the DC 0 to 3, but we need to be aware of what components it takes in. Okay. In 2006, a survey was developed and distributed through the Autism Network, I think is who hosted that. And the purpose was to gather information. What are services, what do they look like out there for children under 4 across the state? It was a web-based survey. They identified interventions being implemented. And after that, in 2007, a group got together and put that into a report. Unfortunately, that report might be lost in hyperspace. We're not quite sure where it is. Our attempts to find it in links, so we're working on that, and hopefully when we get the connection or understand where it went, we'll send that on to the center and they can put it on their website. Phil and I looked for it and we couldn't find it. So it helped identify professional needs, and it helped us look at what is out there and what's needed out there. Some of the things that were identified, which will be no surprise to any of you who work in the field with families and children, was that more time, more training. A very critical thing that came out of that was how do we, as educators out there servicing children, how do we train parents to effectively intervene, to utilize evidence-based practice? So the field was saying, help us know how to do that. So alas, the collaboration and the importance of it, because as educators, we have a training level that is certainly much different than the medical field and the clinical field. So we sort of want to look at that. And looking at just one of the slides from there, the intervention methods that were reported, you could see being an educational field, of course, and the diagnosis of ASD, speech and language pathologist was certainly the highest, then PACS, sensory integration, occupational therapy. So again, we'll be looking for the report and we'll find it. UFO sighting, we'll find it and get it back. Now we're going to look a little bit at collaboration.
Collaboration can look different in different agencies with different professionals, with different people involved. And we have the opportunity to show you two. Unfortunately, one of these videos, only one will work. So we're going to listen to the parent. We're hopeful that at a later date, the professional perspective can be viewed via link. Unfortunately, it's not matching our systems this morning, so we had a glitch in showing it. But this is one example.
One thing that's been really helpful is to have our case manager attend our IEP meetings with the school. Our son started kindergarten this year, which is a huge challenge. We didn't see how that was going to work. He loved day treatment, made friends here, loved the staff, felt really comfortable, was really succeeding. To leave all that behind and start a whole new school, big classroom, new staff, new environment, new routine was really intimidating for him and for us. So we had our Fraser case manager attend our IEP meetings and work with us and the school staff to just so that one, the right hand knew what the left hand was doing. And because of that, then we were also able to put his school occupational therapist in touch with his Fraser OT and the Fraser psychologist, working with both of them on anxiety coping techniques in an OT setting. And I think that really, that carryover really helped.
what we would have seen on the professional perspective is the teacher here and the school psychologist went and did a presentation to the hospital board down in their local area, which was New Prague. And from that, an ongoing collaboration has sustained. The physician, Dr. Ann Snyder's in here, talks about she didn't know that she could refer kids under 3. And they meet maybe 2 or 3 times a year for lunch, and they continue that ongoing relationship. So sometimes when we say, how do we start the process of collaboration, it might be a PowerPoint and a Subway sandwich, and it evolves. So we're hoping to get this started, and I apologize to them because we had a lot of back and forth trying to get this done, and they did a great job. Collaboration around services, understand the components of evidence-based practice, and that's really become important for us in education as a requirement. We're required to certainly look at that. Here's some resources for you. The National Autism Center, it has resources to promote the dissemination of information. They've taken on a nice project, the National Standards Project, to help get some guidelines to how they are evaluating evidence-based practices and studies. So that will be coming out, I'm hoping, shortly. And also the National Professional Development Center on Autism Spectrum Disorders. It's a multi-university center to promote the use of evidence-based practice for children and adolescents. The Minnesota Department of Ed was lucky enough to be chosen as one of the 3 states in the Year 2 cohort. So that'll be starting this year. And hopefully it'll help us better define. If any of you haven't been on to what we call the O'Kelly Internet modules, public domain, they're free, you sign up, and they're training videos, evaluation, assessment, different one. It's a great way to certainly inform yourself, inform your staff, inform parents, and learn a little bit better what's going on across systems. And with relationships specifically to early childhood, the National Early Childhood Technical Assistance Center, or NECTEC, provides great information about children in general. It has a lot of information on autism, evidence-based practice, eligibility, all our rules, all our guidelines. Going back to the National Standards Project goals, they want to organize a network of individuals and agencies to ratify a set of national standards derived from the empirical literature. Last I heard, I think they looked at 720 or 750 different studies. They have a very systematic way of looking at how will we look and how will we define what we consider evidence-based. And then they're going to have a strength of evidence classification system. So they're going to look at those, the literature and say, okay, in there, what was the strength of evidence within them? And then they'll have a rating system that goes from strongest evidence to strong evidence to emerging to unestablished, ineffective, or harmful. So you can request a copy of that, sign up to get a copy of that, and that will be helpful for anyone in the field, I think. I like to think of it as maybe a consumer report, and the woman who's heading this defined it as you probably don't have a, if you Google evidence-based practice or practice in autism, how many hundreds of thousands of matches will come up as a hit? And you're trying to give those to probably the most vulnerable population, the parents of these children. So how do they help decide? So I think it'll be a nice start to help us become more informed consumers as we try and help the system and help parents. Oh, okay, that's me. And I think Wendy went through this, there's not one method, there's not one strategy. It's a continuum of the evidence strengths, and it has to be supported by multiple sources of data. And we need to be informed consumers ourselves. And once we get guidelines, that doesn't mean it can be a cookbook. We need to stay current, certainly in the field.
So in terms of taking us back to collaboration again, evidence-based practice provides us with the guidelines to help collaborate around, but we need to return to adapt our methods to support interventions that are matched for the component of autism, for the developmental level of the child, for those unique child characteristics and those family characteristics that you learn over the course of your work with the families. And then we have an example, same parent talking about after being in intervention for over 2 years with lots of clinicians, lots of appointments, and talking about the transition to from early childhood to kindergarten. And so this is one example.
But one of the most helpful things that we could have done was, Hank was having a lot of trouble at kindergarten. The day was too long, too many changes. He was sort of lost in the crowd, and we were really concerned. We basically showed up at a meeting and said, this isn't working, we're going to homeschool. Thank you for trying. But our Fraser case manager was there, and he had suggested that we could perhaps bring in a behavioral aide from Fraser, someone that Hank knew and trusted already. That would allow my husband and me to sort of step back and not try and be there at school making it work, because that was just confusing and difficult for everyone. And amazingly, the school system agreed to this under certain conditions. They agreed that we could bring someone in on a temporary basis. But having him there in the meeting while we were all really talking about the nitty-gritty of my child's day and how it was all working, for him to bring it up there in that meeting and say, what about a behavioral aid? And then he was able, because he was there, he could explain to them what that would look like, what a behavioral aid does, and have the school and Fraser both there agreeing that it would be temporary and just agreeing to all the conditions. So that was critical. We brought in a behavioral aid from Fraser, someone he knew and trusted and had worked with here for, I think it was about 6 weeks, 4 to 6 weeks at the school. She walked him through his day. And then the other parents in the classroom there were able to see how she worked with him and be able to model that behavior and get some tips for what worked. But the most important thing was probably that it gave him, my son, a friendly face and someone he trusted to help him make the transition from Fraser to school. And because of that, and when her time was up, I thought, well, any day now, this is going to stop working now that she's gone and we're going to have to pull him out. But it has been a smooth transition, partly because she was so successful at easing back out and letting them take over.
Very quickly, to summarize, lots of questions about how to go about the collaboration. Most of us don't have a lot of resources, time, finances to pay for this piece, but it is really important, and we have to buy in. Collaboration up front pays off for the long-term continuity of service. It is a way of thinking and acting. It's not just one action. It's a process that's more timely but more thorough and supports families. It's a model for families to use and to collaborate with others as they move through other systems. So we encourage you to think outside the box, think about where collaboration can fit in to pull together those services for children with ASD and their family.
We certainly know the benefits of it. We'll all have an increased knowledge base. We're going to, most importantly, though, and this is what we tried to focus on, we're going to improve services to children and families. We're going to enhance resources. We'll all learn from one another, and that relationship building will be beneficial to the families and the children we serve in the future.
And we've already talked about some of the challenges, but I encourage you to think about some of the challenges as a way to reframe things. So when parents are coming back and saying, somebody disagreed with your opinion, this is not the intervention he should be getting, or this is not the diagnosis, to step back and look at how a framework might be different, so then instead of conflict amongst the different agencies, we can say, well, there are some components that we do agree on, and actually there's quite a bit we agree on if we look at things. So use this as an opportunity to think differently about how you're approaching interventions, and in a way, again, it's a team approach so that we can share in meeting the needs of what the families are coming in requesting for their children with ASD.
Here's our stop sign from our timer coming up. So just some resources and contact. And that concludes it. Thanks.
Thanks.
So the floor is open for questions.
How do we access the PowerPoint so we can click on those hyperlinks? What's the address?
I'm sorry, I was directed to cover that and I forgot to. They will all be on the Center for Excellence website, which is www.cmh.umn.edu. And I believe that information is in your folder. Same place you went to register.
We have two questions. Dr. Stone, would you address anything you know? I'm over here. Over here.
Here.
Yoo-hoo. ASD in babies with prematurity. And then, Mary, would you please discuss LRE services for children under 3? Your take on that and the challenges that we oftentimes have.
So there have been some studies that have come out about high rates of autism in ICU follow-up clinics. Is that what you're referring to? And those, most of them have used the MChat without the follow-up interview. So you're going to get elevated rates. I think are there 2 studies? So one of them used the MChat. The newest one, you also used the MChat and showed high rates of autism. Well, the short story is that certainly any biological or environmental event that places a child at risk for any developmental disorder is going to also elevate the risk for autism. I mean, and whether the rates are excessively high in that population is really not yet known. I think it's an important question. I think that MChat isn't a good way. You really want to do a diagnostic evaluation because we also saw that the MChat over-identifies, especially in young children, and they were used. So So I don't know that we've established a clear link between autism and prematurity.
Okay. And now the LRE question. I think for children under 3, we look at it as service provision in the natural environment. For children over 3, we look at services provided in the least restrictive environment. And now I'm starting to use educational jargon for the non-educators. I apologize. IDEA and the federal government require and ask that services be given in either the natural environment for Part C or for Part B kids 3 through 21 in the least restrictive. However, every decision, they're called individual family service plans and individual education plans. So you have to look at the needs of each child individually. And I know for the IFSP, if they decide that the natural environment is not going to be used, you're required to put on there why. So there's a documentation on those forms to say, if I'm not using it, why am I not using it? I'm hoping that answered your question.
So we have a question in the back.
Yes, I would like Dr. Stone to talk about accessing the STAT training. How do you go about doing that?
Okay, so we have done workshops. I'm sorry, it's like I can't even see you. We have done workshops on the STAT for years and years and years. You can come to a training workshop there at Vanderbilt, but soon we've been working on a training, a web-based training tutorial that's almost ready, but I've been saying that for a long time. So, so one could wait for the training module, or one could come to Vanderbilt. Sometimes we can do them. We can go somewhere to provide the training if there are enough people, but that's more costly. If you take the training and you get certified, then you can train other people where you work. But we encourage you to use the same methods that we use, which is having them look at videotapes, you observing them either on tapes or live and giving feedback. So it's available. There's a website also. You can see I didn't come here to sell the STAT because I can't even. So if you typed in Vanderbilt STAT, one would hope that you would get to the triad and try those 3 things. You should get, because there is a website now with
Or
information.
you can send me the link, we'll put it up.
Well, that has to be on my list of things to do.
We'll remind
There
you.
she is. Oh, there she is. I can't tell where the voices are coming from.
Follow the point.
Question over there.
Hi, I was wondering if there's any research on the environmental factors between ASD SIBs and typically developing SIBs and how that relates to their scaffolding they're getting at home, if that's part of the risk factors.
How that relates to what?
The scaffolding the SIB sees from the child with autism, if that's relating to some of those higher risk factors, but
Okay, so you mean the family environment as opposed to the external poisons in our environment. So certainly a family with a child with autism has some stresses that families without a child with autism do not have. That really hasn't been, we know that families are more stressed when they have a child with autism than when they have a child with another disability, I think, disorder. That's like, there's been a fair bit of research on that. But we haven't gotten to the point of how that affects their behavior so much. And so it could be positive or negative in some ways. I mean, a hypervigilant parent who's concerned might have learned strategies that they can then, with their older child, that they can then use with their younger child. At the same time, they may not want to consider. I mean, there's just a jillion different scenarios. So I do not think that's been teased out well yet, but I think it will be. With these new studies on parent implemented interventions, more parental factors are being studied for very young and their influence on very young children. So I think we'll know more about that in a year or two. Is that?
We actually have a question from one of our remote sites in Rochester that I think kind of dovetails with that question that she just asked. And the question is, what does the research suggest, or what are the findings regarding ASD and identical versus fraternal twins?
So autism is one of the most heritable disorders, meaning that there's no question that there's a genetic component. There are higher rates in identical twins than in fraternal twins than in siblings. But the rates for identical twins it's not 100%, which makes us know that there are also environmental contributions, whether it's, who knows what it is. So I don't remember the ranges, but for each category. So I can't really, I would be making it up. But it's easy. It's high. It's higher for identical. Is that close to the answer?
I'm sorry, you need to speak in a microphone, otherwise people can't
I'm sorry,
hear you.
it still doesn't speak to the environmental because that's just a big question mark.
And you're talking about family environment or
Right.
big environment? Yeah, we don't know. I mean, there are, children develop in a context, and the context has whatever was chemicals, neurotransmitters that were around when they were in the womb, to family factors, to parenting, to family stress, to where they live. So, I mean, you can't downplay those. You can measure them, but we don't know. One thing, which is another related, maybe common question is, well, could the younger sibling just be learning the behaviors from the older sibling? And that I have an answer to, because you can't learn the lack of things. There are social models in the home and in the environment for social and communication behaviors. There are models. So, you can learn flapping from your older sibling, but that's not, is not going to make it. So that I feel confident about. But certainly, and somebody asked me this, I believe, in the restroom. Well, I mean, the way parents react to their child is, it's a whole cyclical thing. I mean, A child who isn't giving you much back emotionally is going to make you worry about your parenting skills, which is going to change your parenting behavior potentially, which is going to influence the child's behavior. So which is why I think that helping parents feel and become more efficacious in their skills and their ability to teach and play with their child is number one priority, especially for the really teeny-weeny children.
Okay. Question over here.
I was told by an early education
Where?
specialist.
Follow the point.
I can't follow. I'm not responding to joint attention well. Because I don't even know where the point's coming from. Okay.
I was told by an early education specialist last week that one of the early signs of autism in infants is that they don't develop equally in their bilateral muscle movement, that their left side may be more advanced than their right side or vice versa. And I haven't heard you say anything remotely like that or about motor development, and I'm wondering whether there's any truth to that.
Okay, so I think there's one study that suggests that is not a well-studied phenomenon, and there's one study that suggested that might be the case, but I think it wasn't a particularly well-designed study, so I don't think that we have any conclusions about asymmetry. I mean, and it may be that with the infant studies that we're doing now that we will see that. People are looking at that now. Jana Iverson at Missouri, somewhere in Missouri, is studying early motor development in younger siblings with children with autism. So there is stuff that's published about showing stereotypies early, but and Amy Weatherby also has a motor scale that has some bilateral, laterality things in it. So I think we'll know more, but I don't think we know that yet.
Question up front here.
Diagnosis of sensory integration dysfunction. I'm wondering if this group would have been in the BAP group that you referred to, or where, I know it's not
a diagnosis
on the autism spectrum, and it's not, my son was diagnosed with it, with fine motor delay, self-care delay, Now he's diagnosed at 8 with ADHD. And I think there's something else going on. We did a lot of OT intervention and stuff like that, but I'm wondering, it doesn't fit into that BAP group. I was having trouble.
Yeah, that BAP group was more social concerns than other things, the sensory issues in autism are also being studied more carefully now. And I think it's a really, really important area of study because, it could be that sensory differences underlie, the social. We just don't know, and it's very important. I think the way it's been approached in the literature hasn't been so. The literature's not strong, but that doesn't mean that the phenomenon doesn't exist. But it means that we don't know as much about it as we could. So, and we are finding more sensory and motor things in the younger, in the very young children. So, and that's, our measurement is becoming more and more focused. So, again, I feel like all I'm saying is, maybe we'll know sometime. But we're just starting this very early research.
I have another question from our distance site in Rochester. Are there different levels of competence expected for males versus female children with ASD?
Or different what?
Competence levels?
Do I have to answer that one?
I don't understand it.
Competence. No, is the short answer. When you're looking at early doll play, like in the stat, you may, I think very young boys may be a little less likely to pass that one item than girls, for example. But I don't expect anything different. There's also literature suggesting that girls are, we know they're much less often diagnosed, but that when they are, they're more seriously cognitively impaired. But we wouldn't automatically expect less or more of them. I think socially we expect more of girls, just within our culture.
The only thing I would add, in a clinic setting, probably we're not having different expectations, but when we see a girl in the context of evaluation, we want to make sure they're tied with a neurologist and a geneticist. So if there is a pattern of development that suggests regression, that Rett's would be something that would be ruled out.
We have a question for Mary Hunt. When testing cognitive development in 3 to 5-year-olds, is it best to use only nonverbal measures for a valid IQ measure because known speech language is important, or should we use verbal and nonverbal subtests?
Well, yes and no. I'll piggyback off yours. And again, I hate to be repetitive, but each child you test is going to present to you with a different referral profile, concerns by the parent. My concern about only using a nonverbal is that I don't know how you tap the atypicality of communication if you haven't used a verbal measure. But I do know, for example, when I worked in Indiana, we were required to give a cognitive test with a nonverbal component. So I think the nonverbal component is very important so that you, many times they say, will give a more optimal measure of ability. But I would be hesitant not to put some verbal testing in there because that's what tells you what your need and interventions may be. It'll give you the mismatch of that child to, when you ask a WH question, if I ask a how question and I get a what answer, it's those kind of it's that kind of testing that's going to define that intervention and need for me. So.
Another question way in the back over there.
Just pat it.
This is a typical what came first, the chicken or the egg? I'm over here. I'm a school psychologist, and I work with parents whose children are either diagnosed with ASD or potentially, and they're 2-year-olds. And yet when we try to talk about intervention or strategies and talk about play, it's like a foreign language to some of these parents. And so when you're attempting to impart strategies that are beneficial for the children, I didn't hear a lot of talk today about that parent relationship and about influencing that piece of this, which is so strong, and yet some of these parents possibly could be undiagnosed as well.
So you want to handle that one? Pat can speak to that.
Is that good? Is that for me? I missed the beginning part of that. So I missed the question.
I guess I'd be encouraged to hear a little bit more about the parent relationship. It's such a strong piece of, birth to 5, and let alone, full development. And just how much are we talking about working with these parents and possibly parents that could have their own undiagnosed ASD?
All right. Well, we know that maternal or caregiver responsivity is really important especially for young children, for promoting social development. Parents are going to vary along that spectrum, whether or not they have another child with autism. And the goal is to help the parent be as responsive as they can be. I don't know how else really to answer that, but yes, I mean, in terms of individualization, family constellations, parent skills, parent motivation are all going to affect how you design your interventions, and you have to be, pretty clever, as I think you all described really well in terms of, matching what the parent. You got to start with what the parent can and will do, and that's why the whole field of prevention and the whole concept of collaboration and models for adult education and are very important, and they're not brought into this field quite yet, as much as they could be.
In the clinic setting, we also see it as essential, and I'll direct you back to some of, if you know the DC 0 to 3, that the 5th axis, looking at social emotional functioning and rating relationships. Most of the children we work with have many caretakers in their day, and it is true that sometimes we're dealing with parents who might have their own needs that might interfere with that relationship, and it is important to look at the broad system and where the resiliencies are. And we even see this in testing when we're trying to do perhaps a Bailey or a Mullen item, and the baby's sitting on a parent's lap and they're rocking them so ferociously that they can't possibly grab the item on the table. And so you get bits and pieces of information about where that parent is coming from and what that relationship is like, and then you guide it. Video is helpful with some parents. They're insightful, they can see what's going on, and they redirect their behavior. And with other parents, it's guide by guide and lots of repetition, and it takes lots of different people on the team saying the same thing. And in some cases I've seen, it's the grandfather who has that link, that relationship, that twinkle in his eye that's going to get this child to respond to the activities, and you get him in more. And so I think there's lots of ways to do that, but it really does take some conversation, I think, about team members and what they're seeing, because not everybody is seeing all the caretakers perhaps during their particular time with the child and the parent.
I've had parents say, it never occurred to me to get on the floor and play with my child, like you're saying. So it's, and then once they see it and try it and get some reward out of it, they feel fine about it.
And they'd love to be acknowledged. I think a great intervention for all of us that's really easy and it can happen on the way from the lobby area back to the room is noticing how well a parent does in engaging that child, whether it be that throw up in the air or the tickle that they gave them, and say that's the kind of interaction that we're talking about, to take the mystique out of what is it that really promotes and scaffolds development for these children.
And that's where the importance of the natural environment, in response to your first question, would come in, because teaching them that in their environment with what they have in their home is important too, as opposed to just coming in with a bag of your special toys, then leaving. So to make sure that if it's embedded across their routines and if it's embedded in their natural environment, then we know it'll probably, hopefully, be more effective.
Question over here.
Yeah, I'm wondering if you could speak more to the 25-hour-a-week intervention. Is that professional intervention, or is that just parent-child appropriate interaction? I know that a lot of the school systems have interpreted it as center-based intervention for toddlers,
right,
with or without parents, or direct, or ABA training for.
Right.
them.
That's a really good question, and it's another one that doesn't really have an answer, because the 25 isn't really a magic number.
15, either end of the boundary.
So, and so for young children, parents have got to be involved, and what parents do at home is critical. So, you could make a formula box, but of what the child needs and who's going to provide it, and it'll look different, and where it's going to be provided. It's going to look different for every child. So, there isn't really an answer as to whether the parent stuff comes within that, I think that's what you're asking, within that 20 hours or 25 hours, or whether it's in addition to that. And I guess, since you just need to develop a program that makes sense for the family, and that includes the parent, and that includes some things that the parent can't do. The parent isn't a speech-language pathologist if the child needs speech-language work, but the parent can implement goals and activities that the speech-language pathologist gives them, maybe. At the same time, the SLP can't, could, but doesn't usually work on in the parent's bathroom and brushing teeth, or, so it's like there are different things for different places, and they're both important, and the relative number of hours is just going to vary.
Well, I'm getting the signal that I think we're out of time. 2 minutes, so we have one last question.
I could just say, I don't know, before they bother asking.
Hi, I guess I could direct this to all of you. Has there been any research on praxis and motor planning as it relates to the development of interactions and imitation with autism and the BAP kind of kids?
Okay. Well, so I got this question in the bathroom too. So children with autism typically are not great imitators when they're young. You know, and whether that and imitation is one of those skills that involves certainly motor planning, but also a social component because you have to want to do it if it's a goofy thing, and representational skills. So it's like one of those things that being not great at imitation, you don't know which of those things it is. Now, the same child who doesn't imitate a wave goodbye could know exactly how to turn on the VCR and push these little buttons and do things in a sequence. So, which says that it may not be, the motor skills. It could be the motor skills in a demand situation, which could suggest that there might be some neurological thing going on. I don't think that's another area. I don't think we know. There are in the restroom question was about dyspraxia in a diagnosis of that instead of autism, and how would they look different? And they would, because in dyspraxia you may have language issues, you may have motor coordination issues, but you're going to have the social. I mean, the social stuff will be okay, and the nonverbal communication should be okay. So those are many ways around that question, I think. But
I think we've run out of time. I want to thank our presenters for an excellent morning, informative, and hopefully it's whet your appetite for more information, which you will find on our website, www.cmh.umn.edu.